So is there a way of finding out who's likely to benefit from this? Do all patients really need 1 year of treatment? Are we over-treating these patients? Probably yes. Is there a way to get better in a patient who is not responding to the neoadjuvant phase of therapy? They did a nice study looking at if you don't have good response to neoadjuvant therapy, should you give immunotherapy to all these patients? And the answer is no. The study clearly showed that the outcomes are detrimental if you did adjuvant immunotherapy to a set of patients who did not respond well to neoadjuvant chemotherapy. So we really don't know what to do there. What are we likely to do in the future, which is scope for escalation of therapy in patients who don't do well and de-escalation of therapy in patients who do very well? So what are the tools and what are the targets that we have? One of the very powerful prognostic tools that we have as of today is something called as circulating tumor DNA. Now we have super techniques to pick up circulating tumor DNA. If somebody at the end of chemo and surgery has no circulating tumor DNA, that patient has got an extremely low likelihood of getting the disease back. So you might scale down on your treatment. While if somebody has a lot of tumor DNA still circulating, that patients need more treatment after surgery because their outcome is extremely poor here. We all talk of targeted therapies, but unfortunately, it's very humbling to say that we haven't been able to make any dent in the localized disease setting with the umpteen number of targeted therapies that we have. We still do good old chemotherapy. How do you get from Matterhorn to Everest, right? Look at targeted therapies. We are trying to look at non-operative management of stomach cancer. You know, it sounds really weird to be talking about non-operative management of localized stomach cancer to a group of surgeons, but that's where this field is moving. And then, as I said, adaptive adjuvant therapies depending upon response. So, as I said, I've left you with more questions, but I will try to give you some answers in my summary slide here. First question, are we treating patients optimally? Probably not. We are putting every single patient through that conveyor belt approach and either over-treating them, under-treating them, except a small percentage of patients who seem to be benefiting from our so-called high-quality interventions. Do we have robust biomarkers to optimize treatment for these patients? Unfortunately, at this point in time, the answer is no. Hopefully, we'll do better in the future. What is the only biomarker that we do for patients with localized stomach cancer? It's called microsatellite instability. We don't really have the time to go into the details of that. Is there a role for targeted therapies in patients with localized stomach cancer? Absolutely not. Good old chemotherapy is where we are. Can we use some tools to treat patients better in the future? Yes, circulating tumor DNA, pathological complete response, better imaging, looking at scopy after neoadjuvant therapy. Is a non-operative approach likely in the future? The answer is a resounding yes, but it's only for a small percentage of patients. We can't claim that everybody who walks into my clinic, I'm going to do something. And finally, the question, are surgeons likely to go out of business? Certainly not. You guys will have a role for many, many, many more decades to come. At least the people sitting here will not run out of business. So absolutely no problem. If you want to learn more, keep watching this space for more news so that you know how optimally you can manage your patients with stomach cancer. Thank you so much.